All right. Welcome to our webinar on management of GERD and hiatal hernia. I'm Dr. Pradeep Pallati. Hello, welcome again. I'm Dr. Pradeep Pallati, a US board certified surgeon recently relocated from US to India. I'm a senior consultant of bariatric and advanced laparoscopic surgery in Yashoda Hospitals, Hyderabad. I'll be talking about management of gastroesophageal reflux disease and hiatal hernias. So, what is GERD? GERD, based on a Montreal consensus, as is a condition which develops when the reflux of stomach contents causes troublesome symptoms and/or complications. The key word here is reflux and troublesome. As you can see, troublesome means patient is to decide when reflux interferes with lifestyle. So, what are the typical gastroesophageal reflux disease symptoms? Heartburn. Everybody talks about the heartburn itself, where you feel like burning behind the heart. You feel the acid regurgitating from the stomach into the esophagus, and patients will complain of burning behind the heart. Typically occurs after half an hour to an hour after eating, and also late at night. Regurgitation is basically the reflux of the food contents, which feels like food coming back from the stomach into the esophagus and the throat. Regurgitation is a very clear symptom of reflux. Heartburn could be functional, could be psychological in some cases, but regurgitation is a clear sign of pure reflux itself. The water brush is a salty salivary hypersecretion, is known as a water brush. Basically, patients complain of significant watering mouth. It is a reflex towards the acid that is coming out into the esophagus, and it's a reflex from the mouth, which is secreting alkaline salivary juices to counteract the acid from the stomach. Dysphagia is a difficulty with the food intake, food getting stuck, is a suggestive of peptic stricture, could be a sign of a typical symptom of GERD. What are atypical symptoms? Atypical symptoms is non-specific chest pain, could be multiple reasons, reflux causing increased esophageal peristalsis, causing chest discomfort, vague indigestion, could be from reflux, but could be multiple other causes. Respiratory symptoms can be considered as typical, but they are atypical in the sense that there are a lot of other reasons why the patients can develop these respiratory symptoms, especially the hoarseness, asthma, wheezing, chronic cough, and dyspnea on exertion. These all could be from the reflex itself, but we cannot confirm that it is typical symptom. So why do we need to care about this GERD? Why do we need to really think about it? Unfortunately, with the increasing fast food environment in the culture presently and high fat intake in the food, we notice that at least 44% of the people will complain of some kind of a reflux symptoms at least once a month. And if you go about once a week, around 20%, and 4 to 7% of the people are complaining of reflux symptoms on a daily basis. Is it troublesome? Yes, but mostly it is noted. And this is the most common gastrointestinal diagnosis in the outpatient visits. If you talk to any doctor, general doctor, this is the most common symptom that people complain: heartburn, chest, and reflux. And the frequency and severity of symptoms do not predict esophagitis. Okay, so it could be the patient is not complaining too much, but they have severe esophagitis or stricture or even progression towards Barrett's esophagus. So we really need to take care of the reflux symptom as such as doctors. What is the etiology? It could be the raised intra-abdominal pressure as a result of central obesity, raised intragastric pressure, gastric hypersecretion, and the abnormal lower esophageal sphincter are all the causes of GERD. Abnormal lower esophageal sphincter is mostly from the food intake. Increased fatty food causes increased lower esophageal sphincter relaxation. And we'll talk about avoiding these foods later on in the management, but these are the causes of the reflux itself. The other thing that I want to talk about today is the hiatal hernia. What is a hiatal hernia? It's where a piece of the stomach is herniating through the esophageal hiatus. What is the esophageal hiatus? Esophageal hiatus is the opening in the diaphragm, and this is a normal anatomy. You can see the diaphragm, and this is the opening. This is the esophagus, and this is stomach, and the distal esophagus or the lower esophageal sphincter, which is noticed by the white dot here, is supposed to be below the diaphragm. When, due to multiple reasons, could be pregnancy, could be fat, obesity, could be multiple other reasons, we don't know why, but when these ligament that is holding the esophagus and the stomach down becomes lax, the stomach starts herniating through this opening in the hiatus itself, and this is called a hiatal hernia. Why do we need to care about it? If you look at it in type 1 or a sliding hiatal hernia, basically the phrenoesophageal ligament is lax and a small piece of the stomach is going up. With every deep inspiration, there is negative pressure in the chest, and that actually pulls the stomach up into the chest. With expiration, the stomach goes down. So a small sliding hiatal hernia is basically what I call a kind of a reducible hernia. When you come to these features where there is a significant disruption of the phrenoesophageal ligament, you see that the posterior stomach or anterior stomach herniates through the defect, and that is a true paraesophageal hernia. In this case, the lower esophageal sphincter is at or below the diaphragmatic hiatus, and this is a type 2 paraesophageal hernia. Type 3 is the most common paraesophageal hernia, where there is a sliding component as well as a paraesophageal hernia component, where there is a significant amount of fundus next to the distal esophagus in the mediastinum itself. A prolonged paraesophageal hernia will eventually create a short esophagus also due to the reflux itself. Type 4 is not shown here, is basically when the sac involves non-gastric contents like bowel or large bowel spleen. So here you can see a paraesophageal hernia. This is the esophageal hiatus, and this is the gastric fundus within the chest. You can see one more here. You can see the lower esophageal sphincter somewhere in this region and fundus next to it. Again, here you can see the G junction and the large fundus, which causes the paraesophageal hernia. How does this uh, how does the reflux progress? Okay, it's a spectrum of disease. Initially, you have non-erosive reflux disease. What does it mean? It means that there's no erosion, there's no injury to the esophagus itself from the reflux. Other than patient complaining of heartburn, there's no true damage to the esophagus in this case, which will eventually progress to erosive disease, where there is esophagitis. We show more of that, which can, on prolonged inflammation, will convert into Barrett's esophagus. And this Barrett's esophagus does have a very high or increased risk of esophageal adenocarcinoma. So that's the reason why we need to worry about the GERD itself. Okay, once we know the GERD, how do we diagnose it? Most of the time, it is done by internist, a primary care doctor, who will notice that you have a typical symptoms, and we give you a medical management, whether it is an antacid or a H2 blocker or a proton pump inhibitor, and you respond to it. That is it. Then in itself is a diagnosis. Okay, that you have a typical GERD symptoms. If you're truly responsive to medications, then you have the actual gastroesophageal reflux disease. We don't need further testing early on. Okay, medications, most of the time, if you do take, you need to take them on a prolonged basis, and they become less effective over time. And beware of patients who never respond to medical management. They complain of heartburn, chest discomfort, and you start them on PPI, whether it's omeprazole, lansoprazole, or pantoprazole, and they do not respond to it. It's most likely functional or other diagnosis rather than a true GERD itself. What is the other diagnostic modality? The radiographic studies, the upper GI contrast study, is one of the gold standard, not gold standard, but say it's a very easy to do test. Grade 1, you have reflux into the distal esophagus only. Based on the reflux of the gastric or the contrast, you can say so grade 1, grade 2 is up to the carina, grade 3 up to the cervical esophagus, grade 4 if there is reflux into the cervical with a wide open cardia, and then you have grade 5 where is reflux into the lungs itself. The endoscopy. Okay, your endoscopy, you will basically see esophagitis. What do you see in the non-erosive reflux disease? In the first stage of the non-erosive reflux disease, you will not notice any reflux on endoscopy itself. You might say, oh, there was some bile in the distal esophagus, but that is very subjective because we usually give some sedation. So the esophagitis, the erosive disease, is what you will diagnose on endoscopy itself. If you look at this classification of the esophagitis, this is a typical case of esophagitis. You can see that streaks of inflammation with some ulceration here and multiple ulcers here. In LA grade A classification, there's only one mucosal break. You can see one or two mucosal breaks that are less than 5 millimeter long. Okay, and in grade B, you have more than 5 millimeter long. This, like this one, is more than 5 millimeter long, and in this case, you can see there's overlap, like a grade C, where there is overlap between the mucosal folds. In grade D, it is circumferential. So this is more of a grade C classic endoscopic finding of esophagitis. What is you will also see the Barrett's esophagus. Okay, on endoscopy you can also find a Barrett's esophagus. It is an acquired abnormality characterized by replacement of normal squamous epithelium with columnar epithelium. You can see this mucosal tongue. You can see there's a nice clear white squamous epithelium which is replaced by the gastric type columnar epithelium, and you can see this tongue of Barrett's esophagus. And it occurs in 10 to 50% of patients with chronic gastroesophageal reflux disease. This is more so seen in American and European Caucasian patients, not so in our Indian population, but the most of the literature is based on this on that population. What is the other one? The gold standard is the pH studies. Here you're actually diagnosing a reflux itself. Okay, this is one lower esophageal sphincter with multiple electrodes. You have multi-impedance pH probe as well nowadays. Okay, we usually keep the tip of the probe 5 centimeters above the lower esophageal sphincter, where the pH sensor is there, and it will sense the acid that is coming from the stomach. For a true diagnosis of reflux disease, we will need to ask the patient to stop the proton pump inhibitor at least 1 week and a H2 blocker at least 24 to 48 hours, and should not be taking any antacids, any over the counter antacids while doing the procedure itself to diagnose it. It basically will sense how much acid is refluxing into the esophagus. In this case, in the ambulatory pH monitoring, the patient is unfortunately keeping a wire through the nose into the esophagus for 24 hours, continuously checking the acid. This is very cumbersome, very inconvenient, and we come up with a newer technique where we use a Bravo capsule. It has a capsule that is attached to the distal esophagus. On endoscopy, we put a capsule into the esophagus, and we check the patient is given a monitor that will be carrying with the patient, and it will sense how much acid you have. And whenever the patient has symptoms of acid, they will monitor it and they will report it, and that's where we can diagnose the reflux symptoms, and we can have a symptom association probability based on that. The Bravo pH is much more convenient for the patient, and also they truly tend to eat regular food that typically eat, which are causing the acidic and reflux symptoms with the Bravo capsule compared to the pH Pro, because you really don't want to eat much with a tube down your throat itself. So what is the basis for that? Based on the pH sensing, you'll diagnose whether how much percentage of total time pH is less than 4, how much of percent of upright time pH is less than 4, supine time, number of reflux episode, number of reflux episode more than 5 minutes, and then longest reflux episode. And based on this, there's a complex algorithm uh, complex algorithm basically which will diagnose the Demister score. And if the Demister score is less than 14.72, it is normal. Anything more than that is a pathological reflux disease. Okay, once we diagnose that you have reflux, how do we manage? Medical management is the mainstay for gastroesophageal reflux disease. Most of the patients are well managed medically. First, you talk about lifestyle changes. You ask them to elevate the head of the bed so that there is gravity that is helping the gastric acid to stay in the stomach and not go into the esophagus when you're lying down at night, because most of the symptoms are late at night when you're sleeping. You avoid eating within 2 to 3 hours of bedtime. So let's say you're sleeping at 10 o'clock, don't eat after 8 o'clock at night, preferably 7 to 8 you are done with the dinner. You lose weight if you're overweight, especially because the central obesity increases the intra-abdominal pressure and is causing the reflux. So if you lose weight, you will have a very significant improvement in reflux symptoms. If you're a smoker, quit smoking, because nicotine itself does relax the lower esophageal sphincter and predispose you to reflux symptoms. Modified diet. This is what I was telling earlier. You have to eat more frequent but smaller meals. If you increase the intergastric tension because of eating large amounts, you will have reflux. So eat small amounts. Avoid fatty or fried food, coffee, ice cream, chocolate, alcohol, stuff that are supposed to that are tend to open up the lower esophageal sphincter and predispose you to reflux symptoms. So avoid those. Then comes the medical drugs management. These are very frequently used in India. We typically everybody who's getting any medications is given a H2 antihistamine, whether it's a cimetidine, ranitidine, famotidine, or most commonly proton-pump inhibitors, including omeprazole, esomeprazole, lansoprazole, pantoprazole. These are so frequently used around here that you will most likely be on some kind of a medications for reflux at this time. Neutralization of gastric acid is done by the magnesium hydroxide or the aluminum hydroxide. A combination of that is typically used as a gel to decrease the reflux acid burning. Prokinetic drugs do help to improve gastric motility and decrease the reflux itself. Okay. Then comes the surgical management. Okay, I'm here, I'm a surgeon, I'm an expert in the surgical management of the reflux symptoms. So I would like to talk more about the surgical management of reflux symptoms. The first and foremost is patient has to wish to control symptoms without medications. Wait, if the medications are controlling, why do we need surgery? Yes, you do not. But let's say you're on medications been 1 year, 2 year, 5 years, and you still continue to need it. Yes, you will need it, unfortunately, if you have a predisposition to reflux. Even with the lifestyle modifications, if you have reflux symptoms, you will continue to need the medications. So if let's say you have been on medication for less 2 to 3 years, it has been shown that if you're on medications for more than 5 years, the cost benefit ratio is towards surgical management. The patient would like to say, okay, I don't want to be on this medication for the rest of my life. I want something to fix it. Surgery is an option. Medical therapy is no longer effective, yes, then in some patients, the medications do not keep working. You can switch medications from one PPI to another PPI, which might help. But if they are not helping any further, surgery is definitely indication. If you have prominent regurgitation component, if your patient is saying, I feel food coming into the throat, I feel like I'm choking with food in my throat, I can't sleep at night lying down, I have to sit up and sleep. This is some patients do have this prominent regurgitation. Medications won't control it. It's like you have a sewage leakage. You can put all kind of smell, all kind of refresheners and all the stuff, but the smell will be better. But the sewage that is coming back up is still going to burn your esophagus. So if you have significant regurgitation component where there's food coming back, your surgery is the treatment for that. If you have a large paraesophageal hiatal hernia and you have symptoms, yeah, surgery is the treatment because there's no other way the hiatal hernia will be fixed. And there are complications of reflux not responding to medical treatment again. Whether you have esophagitis, if you have grade 1 to grade 2 esophagitis, usually medications will very well manage it and you will respond well. You do need a repeat endoscopy to confirm that the esophagus is well healed. But if there is not, you probably should go for surgery. If there is significant bleeding, if there is stricture, if there is mucosal ulceration, you need to consider surgery. What is the preoperative evaluation for a surgical management of a patient with chronic GERD or hiatal hernia? First, we have to confirm there is presence and severity of reflux. Okay, you have reflux symptoms, good enough. Your response to medications, good enough. Then we usually recommend an upper GI contrast study to actually study. It is not the study to diagnose the reflux, but it will give you a good anatomy, but also will give you a significant amount of reflux. It may not pick up reflux while you're doing the study. So it's not like if you don't have reflux and contrast, it doesn't mean that you do not have reflux, but it is a good study to start with. Endoscopy is a must to see if there is any mucosal damage, if there is any Barrett's esophagus, or if there is any other reason for reflux symptoms. pH probe studies are the final gold standard for reflux symptoms. Okay, you might say, doc, my patients don't want this probe in the nose. They don't want this capsule. They don't want endoscopy done. Is there any easier way to diagnose? Yes, if you do have an endoscopy which shows clear-cut esophagitis and you have a large hiatal hernia, you probably won't need any pH probe study to diagnose that you have true reflux. Definite esophagus, define the anatomy itself. Contrast study is the study that will give you a clear-cut definition of anatomy. You also will do endoscopy with biopsy to know where exactly the lower esophageal sphincter is. You may need a chest CT, but you do not need it routinely. We have to rule out any esophageal gastric motility disorders. Manometry is a must if you're going for surgery to diagnose the esophageal motility, and you do not you want to rule out any underlying achalasia, any esophageal dysmotility prior to doing a fundoplication. Upper GI contrast study is a basic study. If you do a video study where you actually see how it's flowing, you will notice that there is a good primary contractions. If there are secondary or tertiary contractions, it will show up on the video contrast study. And that is also a good baseline test for motility of the esophagus itself. You may need a nuclear medicine gastric emptying study. If there is a concern that there is a delayed gastric emptying, you will notice on the endoscopy, if there is still a food contents on endoscopy, you may consider that to definitely get a gastric emptying study. If the patient does not have a true symptoms, you may not need it early on, but a good upper GI contrast study will give a good pre-op evaluation for the rest of the surgery itself. What are the principles of surgical treatment? If there is any hiatal hernia defect, close it fast. Mesh if needed. Bring the lower esophageal sphincter into the abdomen. Make esophageal lengthening procedure if needed, but also necessary. Recreate effective lower esophageal sphincter, whether you do a total fundoplication, partial fundoplication, posterior fundoplication, anterior fundoplication, or a Hill's procedure. You need to create an effective lower esophageal sphincter to control the reflux symptoms. Here you can see a video of a hiatal hernia repair done by me. Here we initially identify the lesser momentum and we divide it to expose the cruise of the right diaphragm. You can see a large, good size hiatal hernia here, and it's a true type 3 paraesophageal hiatal hernia. We are dissecting the right cruise of the diaphragm. So you can see the big opening of the cruise here that is causing the hernia itself, and that needs to be fixed to if the patient needs symptom control. You go on the left side, dissect the left cruise after taking down the short gastrics here. You can see the nice hernia sac above, and here I'm dissecting anteriorly. The hernia sac is reduced, but you really need to take down the entire hernia sac throughout laterally, anteriorly, medially, and in a short while you'll see I'll go to posterior dissection. Here, this is a cotton candy caul, which is dissected in the mediastinum to get the esophagus down into the abdomen. Here you can see the posterior dissection is done. You can see clearly the posterior vagus now here, the nice thick posterior vagus now. Dissection is continued posteriorly behind it. I place a Penrose drain for easy retraction of the distal esophagus in the stomach. You really need to make sure there is no raised RT inside the esophagus at this time because it can damage the esophagus. Once that is reduced, continue dissection to the mediastinum. You will need a good 10 centimeter of dissection into the mediastinum to adequately make sure that you have good distal esophagus and that the esophagus is lower esophageal sphincter is lying freely and comfortably in the abdominal cavity. Now that you can see the esophagus is nicely, here is the esophagus, you can see nicely in the abdomen. Now I start closing the hernia defect. The posteriorly, the cruise will come nicely approximating itself. So you need to start posteriorly as much as possible. You can see here my left hand instrument is pushing the aorta and going as close to the aorta as possible to close the posterior defect very well. I usually use a figure of eight sutures. Some surgeons use a pledger, some use mattress, simple mattress, different techniques, but needs a very good non-absorbable suture with a large bites to take the muscle very well and well approximated crura itself. So that's how we close the uh, hiatal hernia. Here is the first stitch, another 2 and 3, final stitch, and you can see that the cruise is very well approximated. The distal esophagus is nice. Well, now you do the fundoplication. I brought the posterior fundus up, place a test stitch after doing the suture maneuver. You can see that the hiatus is snug around the distal esophagus here. You can see a nice 2 to 3 centimeter of the distal esophagus. And in this case, I'm doing a posterior fundoplication, posterior partial fundoplication, which is a two-per fundoplication itself. You can see I use total of 6 sutures here, and you can see that a good posterior fundoplication is done. We can have a lot of debate about what kind of fundoplication to do, which is a big topic of discussion by itself. So I'll just go with a simple discussion of what are the long-term patient-reported outcomes of parasitical hernia repair. Here you have a nice study from a Journal of Laparoscopic Surgery. You have follow-up of up to 7 years for laparoscopy and open group, and you can see that the dysphagia, heartburn, and regurgitation improved in 95% of patients. Okay, so that's a significant amount of response to the surgery. So you're talking about less than 5% of the people are not responsive to dysphagia or heartburn. Okay, and the laparoscopic and the open repair is 90%. You still need some medications. Some patients still are requiring some medications after the surgery, after a while, for their symptom control, but are able to control very well in 54% of the patients. In each group, 90% state that they would still choose to have the operation if they need it again. So this is a very, very happy patient who has got significant improvement in their reflux and regurgitation symptoms and are feeling much better with surgery itself. The New England Journal of Medicine come up with a recent VA study from America, which showed in 2019 they did a randomized trial of medical versus surgical treatment. This is a very good randomization. You have patients who are undergoing surgery, patients who are being treated very well with medical management, and also patients who are on placebo treatment. So you can see even with a controlled placebo, 3 patients were happy with their treatment overall by the end of 1 year. But with active medical treatment, only 7 out of 25 were happy, and with the surgery, more than two-thirds were happy with their success. So although truly PPI refractory acid reflux related heartburn is seen in minority of patients. So they were looking at almost 360 patients, and only 78 patients actually had a PPI refractory and reflux related heartburn. So there was a lot of people who were psychosomatic reflux and functional GERD also there. But in patients who are purely selective, your surgery is very better than medical management. So in conclusion, PPIs work well for chronic GERD, but will need lifelong treatment for symptom control. Surgery is successful in patients who are truly GERD patients who respond to medical treatment prior. Having surgery in a patient-centered decision in case of GERD only. So if you do not have a parasitical hernia and you have reflux symptoms, it's a patient who will say how troublesome their reflux is and whether it should undergo surgery or not is a patient-centered decision. Largely symptomatic parasitical hernias will need surgical intervention and will do well after surgery. Thank you. Now we'll take some questions here. Let's see the questions here. You might say, what is the success rate? Okay, so somebody asking, what is the success rate of the surgery itself? Like I mentioned, around more than 95% of the people are happy with their reflux and heartburn. Some people will require to take an antacid or a proton inhibitor later on, but it's that is in a minority. So most of the patients will be happy with their surgery. Okay, next question. How long do I need to take time off after surgery? Okay, like I showed you the video, that it's a laparoscopic surgery. I usually do with 4 small keyholes. Surgery takes around 2 to 2.5 hours, depending on how large the parasitical hernia is, how large the reflux hiatal hernia is, and you're in the hospital for overnight, basically on a liquid diet immediately after surgery. Because of the surgery itself, there is some edema around the esophagus or the food pipe, and that will limit how much you're able to eat immediately after surgery. So we usually recommend you to be on a liquid diet for first 2 to 3 days, and after that, baby food, basically any food that you can eat, small amounts the babies can eat. You'll be on a liquid diet for at least 2 weeks, baby food for 2 weeks, and after that, you'll slowly progress on the diet. So you will be in the hospital for only maybe 24 to 48 hours. So you'll be able to go home the next day or the day after, depending on how much your pain have. And after you go home, you'll be on for 1 to 2 weeks. You'll be laid out, but after that, you should be able to go back to work. Do I need medications after surgery? The goal is to get you off these medications itself. Like I said, more than two-thirds of the people at least will be off the medication for the rest of their life with a good reflux control. Does it mean that I can go and eat large pizza and not have any reflux symptoms? Probably not. You need to be healthy eating, but yes, you'll be able to eat significantly well, even a pizza, and not feel any heartburn at all. Um, any other questions?
No, sir, that's all.
All right. No other questions, but do watch the video. We have more of these videos on YouTube about the parietal hiatal hernia repairs. And if you have any questions, please contact our Yashoda Hospitals and contact me for uh, treatment. Take care.
Thank you, sir.